This next set of videos will cover the antipsychotic drug class. The first video in the series will focus on an introduction and the basic pharmacology of antipsychotic drugs. Subsequent videos will talk more about the clinical pharmacology as well as specific antipsychotic drugs, followed at the end by a summary of what was discussed. Antipsychotics are a group of drugs that serve as first-line therapy for diseases that involve psychosis. This certainly does include schizophrenia, as well as other disease states characterized by the presence of psychosis as a symptom. Most antipsychotics are antagonists of the dopamine D2 receptor, and we'll spend much more time discussing that aspect in a moment. In addition to being used for diseases involving psychosis, antipsychotics are also widely used for agitation, irritability, and other severe behavioral disturbances. The reason they are effective for these purposes is because they can calm down patients without producing excessive sedation, thus allowing healthcare providers to talk to the patients in a more calm and relaxed state. If you take away only one thing from this series of videos, it is the statement that is shown on your screen. All effective antipsychotics are dopamine D2 receptor antagonists. I touched on this briefly already, but as the graphic on the screen demonstrates, there is a direct and positive correlation between the potency or the affinity of antipsychotic drugs at the dopamine D2 receptor and their clinical efficacy in treating schizophrenia and psychosis. This same direct positive correlation is not seen for activity at other neurotransmitter receptors, such as serotonin, alpha 1 adrenergic, and histamine H1 receptors. This activity, therefore, forms the basis of the mechanism of action of all antipsychotic drugs. Their basic mechanism of action is to inhibit dopamine D2 receptors, as well as some other dopamine receptor subtypes, at a dopaminergic neuron synapse. Inhibition of dopamine D2 receptors, in general, decreases dopaminergic signaling. In addition to their antagonist effects at dopamine D2 receptors, which serve as the basis for their therapeutic effects, all antipsychotics exhibit some combination of activity at 3 additional neurotransmitter receptors. These include the histamine H1 receptor, the muscarinic M1 receptor, and the alpha 1 adrenergic receptor. The dopamine D2 antagonist activity is considered an on-target effect of these drugs because it is that activity that results in a reduction of psychotic symptoms. The antagonist activity at histamine H1, muscarinic M1, and alpha 1 adrenergic are all considered off-target effects, and these activities are responsible for side effects of these agents. To review, histamine antagonist activity is associated with sedation and weight gain. Muscarinic antagonist activity is associated with anticholinergic effects, including dry mucous membranes, redness, flushing, urinary retention, and some CNS stimulating type effects. Side effects mediated by alpha 1 adrenergic antagonist activity include orthostatic hypotension. The previous few slides covered the basic pharmacology and mechanism of action of all drugs within the antipsychotic class. The antipsychotic drug class can be further divided into 2 pharmacologic classes termed first-generation antipsychotics, or FGAs, and second-generation antipsychotics, or SGAs. Again, these are pharmacologic classes because they are created and separated on the basis of slight differences in both pharmacologic activity and side effects. Let's start with looking at the mechanism of action compared between the two classes. First generation antipsychotics are all dopamine D2 receptor antagonists. They all also have off-target effects at alpha 1, M1, and H1 receptors. In general, the first generation antipsychotics all have equivalent efficacy when used at equipotent doses. Where they differ is in their relative potency and the side effects that they produce. Second generation antipsychotics all also have dopamine D2 receptor antagonist activity. However, in addition, they also possess serotonin 5-HT2A receptor antagonist activity. Second generation antipsychotics also block alpha 1, M1, and H1 to produce off target effects. In general, second generation antipsychotics have a higher potency or affinity at 5-HT2A than they do at the dopamine D2 receptor. The graphic on the screen demonstrates the difference in affinity for the dopamine D2 receptor between first generation and second generation antipsychotics. Shown in the figure is the affinity for the dopamine D2 receptor of the various drugs listed. The blue line is the affinity of dopamine. Drugs below the line have a higher affinity for the receptor than dopamine, meaning they bind more tightly and kick dopamine off the receptor very easily. Drugs above the blue line have a lower affinity than dopamine and therefore are less likely to replace or prevent dopamine from binding. As you can see, there is a fairly clear distinction between the first generation antipsychotics in red and the second generation antipsychotics in black, where the first generation antipsychotics have significant dopamine D2 affinity, which is much lower than that of dopamine itself, whereas the second generation antipsychotics typically have an affinity that is higher than dopamine. We'll talk more about the specific drugs later, but for now, the first generation antipsychotics include drugs like haloperidol and fluphenazine, whereas the second generation antipsychotics include drugs like olanzapine and clozapine. In addition to looking at the receptor affinity of various antipsychotics for the dopamine D2 receptor, we can also look at their affinity to other receptor subtypes. The first generation antipsychotics are listed above the black line, haloperidol, fluphenazine, and chlorpromazine, whereas below the black line, these are all second generation antipsychotics. Again, to remind you of some basic pharmacologic concepts, the lower the affinity value, the stronger the binding to the receptor, and the more likely that drug is to kick off or prevent the endogenous neurotransmitter from binding. Keep in mind that all of the antipsychotics are antagonists at all of these receptors, which means they do not produce any stimulated activity when bound to the receptor, but they do potentially prevent the endogenous neurotransmitter from binding. Let's take a look at the first generation antipsychotics. As you can see, all of them very tightly bind the dopamine D2 receptor. A few of them do have some affinity at the 5-HT2A receptor, but this is lower affinity than at the dopamine D2 receptor. Looking at their off-target effects, the lower the number associated with one of the off-target receptors, the more likely they are to produce those effects. So for example, fluphenazine has the lowest affinity for the alpha-1 adrenergic receptor, and therefore is most likely to produce orthostatic hypotension as a side effect. Chlorpromazine is also likely to produce orthostatic hypotension as a side effect, as well as antihistamine side effects like sedation and weight gain, given its relatively high affinity for the histamine H1 receptor. Now let's take a look at the second generation antipsychotics below the black line. Again, most of these agents do have affinity for the dopamine D2 receptor, in addition to relatively strong affinity at the serotonin 5-HT2A receptor. And in most cases, the potency or affinity for 5-HT2A is greater than that for dopamine D2. We can also look at the side effects for some of these agents. For example, risperidone and paliperidone have high affinity for alpha-1 adrenergic receptors and may produce orthostatic hypotension as a side effect, whereas olanzapine has relatively high affinity for muscarinic M1 and histamine H1 receptors, which could result in anticholinergic and antihistamine effects. The graphic shown here provides a pictorial representation of the affinity of various antipsychotic drugs for the neurotransmitter receptors we've been discussing. Whereas the first generation antipsychotic, haloperidol, has very strong affinity for the dopamine D2 receptor and lower affinity for other receptors, the second generation antipsychotics, clozapine, risperidone, etc., all have relatively high affinity for the serotonin 5-HT2A receptor in comparison with other neurotransmitter receptors. Now is a good time to pause and review what we've covered this far, especially as it relates to receptor affinity. Take a moment to test yourself using the table below. Which of the drugs listed has the highest affinity for the D2 receptor? Which drug has the highest affinity for the serotonin 5-HT2A receptor? What about M1, alpha 1, and H1? Again, keep in mind that the lower the number, the higher the affinity. If you need some assistance coming up with challenge questions to help quiz yourself on this material, don't hesitate to contact me via email or to attend the chat session on this topic. In general, for assessment of this material, I don't expect you to have memorized these affinity values or to associate them with a specific drug agent. What I will ask you, however, is to interpret information from a table such as the one shown on your screen. So be sure you understand what the values in the table mean and how to interpret them.